Hello everyone, good day. My name is Ray Carlinda, and for today I will be discussing all about the two ways in monitoring the fetal heart rate. So first, what is fetal heart rate monitoring? So it is a procedure used to evaluate the well-being of the fetus by assessing the rate and the rhythm of the fetal heartbeat. So during late pregnancy and labor, your physician may recommend monitoring the fetal heart rate and other functions. The average fetal heart rate is between 110 and 160 beats per minute and can vary 5 to 25 beats per minute. The fetal heart rate may change as the fetus responds to the conditions in the uterus. An abnormal fetal heart rate or pattern may indicate that the fetus is not getting enough oxygen. So, there are two ways to monitor the fetal heart rate. First is the external fetal monitoring. It is a non-invasive. It uses a device to listen or to record the fetal heartbeat through the mother's abdomen. So, what are the devices they use in external monitoring? So, first is the stethoscope. Stethoscope used to listen to fetal heartbeat. Next is the fetoscope, a type of stethoscope. It is the most basic type of external monitor used to listen to fetal heartbeat. Next is the electronic fetal Doppler. It is a handheld ultrasound transducer used to detect the fetal heartbeat for prenatal care. A fetoscope or a Doppler device may also be used to check the fetal heart rate at regular intervals during labor. And next is the continuous electronic fetal heart monitoring. It is an ultrasound transducer placed to the mother's abdomen, conducts the sounds of fetal heart to a computer. The rate and the pattern of the fetal heart are displayed on the computer screen and printed on a special graph paper. Next is the internal fetal monitoring. Internal fetal monitoring uses an electronic transducer connected directly to fetal skin. It is a wire electrode is attached to the fetal scalp or other body part through the cervical opening and is connected to the monitor. This type of electrode is sometimes called spiral or scalp electrode. It provides a more accurate and consistent transmission of the fetal heart rate.
So what are the three unique risk factors for fetus? We have the factor of uterine contraction, factor of cord accident, and factor of head compression. Factor of uterine contractions, a uterine contraction during childbirth can be defined as the tightening motion of the uterus as a part of childbirthing process. Factor of cord accident occurs when the baby's umbilical cord becomes flattened by pressure. A flattened or compressed cord can restrict blood flow and oxygen to the baby. Factor of head compression, excessive pressure of the baby's head can cause hypoxic ischemic brain damage, and other birth injuries can reduce blood flow and oxygenation within the brain. So the importance of knowing those risk factors can help prevent complication and inform women about important steps by protect their infant and ensure healthy pregnancy. Within regular prenatal care, women can reduce the risk of pregnancy complications.
Hi, I'm Janila de Guzman from BSN2B. So there are features that describe the fetal heart rate. If it's higher and outside the baseline or the normal baseline, it is called fetal tachycardia. It is higher than 160 beats per minute, and the possible causes are. And if it's outside and lower than the normal baseline, or it is less than 110 beats per minute, it is called fetal bradycardia, and the possible causes are. And it is called indeterminate. The fetal heart rate is called indeterminate if the baseline is present for less than 2 minutes.
Okay, so let me start this by defining what fetal heart rate baseline variability is. So based on my understanding, fetal heart rate baseline variability is the changes between consecutive fetal heartbeats that happen within 16 to 30 seconds of one another. So it's often normal variation, but in some cases, it can indicate the onset of fetal distress. So the grades of fluctuation are based on amplitude range. So the first one is the absent variability, which amplitude range are undetectable. Then the next one is the minimal, that is less than 5 beats per minute, followed by moderate, that basically equal to 6 to 5 beats per minute. Then lastly, the marked, that is greater than 25 beats per minute. So now, the importance of knowing it is that it can reveal whether or not there is an issue. So as fetal heart monitoring is the method of checking your baby's heart rate during childbirth. So your baby's heart rate is a strong indicator of how well he or she is doing. So it can reveal if there is it.
Good day, I am Kimberly Gamio from BSN2B and Beverly Gamio from BSN2B. And for today, we will talk about the periodic fetal heart rate changes. So periodic fetal heart rate changes is the temporary recurring changes in the fetal heart rate baseline occurring in relation to the uterine contractions. So there are 4 types: the acceleration, early deceleration, late deceleration, and the variable deceleration. So acceleration, it is the abrupt increase in fetal heart rate above the baseline. So ito yung pagtaas ng heart rate. So for the more than 32 weeks of gestation, there is at least 15 beats per minute and must last at least 15 seconds or what we call the 15 by 15 rule. If it is less than 32 weeks of gestation, there's at least 10 beats per minute and must last at least 10 seconds or the 10 by 10 rule unless previously demonstrated by 15 by 15 rule. So early prolonged acceleration must last at least 2 minutes but fewer than 10 minutes. So minimum of 2 minutes but not go over the 10 minutes. So the maximum of 9 minutes. Dapat hindi siya lalagpas sa 10 minutes. So baseline changes, it is last 10 minutes or longer. So let's go to the deceleration. Kung yung acceleration is increase or pagtaas ng fetal heart rate, yung deceleration naman is yung pagbaba ng fetal heart rate below the baseline. So there are 3 types of deceleration. The early, late, and variable deceleration. So early deceleration, ito yung symmetrical dapat siya sa contraction ni mother and sa heartbeat or heart rate ng fetus. Dapat, ito yung tinatawag nilang mirroring images. So early deceleration, ito yung unti-unting pagbaba ng fetal heart rate. So it occurs 30 seconds or more from the onset to the nadir. So ang nagkukos ng early deceleration is yung head compression sa birth canal ni mother. So it is not concerning as long as yung fetal heart rate stays within the normal range, which is 110 to 160 beats per minute, and we should monitor the patient and document. So let's talk about late deceleration. Late deceleration is delayed in timing. So nag-occur siya after peak contraction ni mother. So nauuna ang contraction ni mother bago yung onset ng fetal heart rate. So ang late deceleration ay nag-indicate ng fetal hypoxia, and it also represents uteroplacental insufficiency. Late deceleration is non-reassuring. So if this happens, we should turn the mother on her left side, also stop the oxytocin infusion, administer O2 with the physician's order. And if the physician is not present, we should only administer 3 liters. And we should also determine the fetal heart rate variability and then contact the physician. So next, we should talk about variable decelerations. Variable deceleration is the abrupt decrease in fetal heart rate. So it happens from the onset to nadir in less than 30 seconds. Variable deceleration also decrease the fetal heart rate, and the common cause of variable decelerations is the umbilical cord compression. And it is also common during labor and can be concerning if recurrent, kung pabalik-balik siya. So if this happens, we should move the mother around, instruct the mother to move around because it could help relieve the cord compression. Also administer oxygen because the cord is being compressed on the fetus, which in turn is causing the baby to not receive enough oxygen. Kunti na lang yung nare-receive ni baby ng oxygen dahil dun sa cord na nakalagay sa kanya. So dapat may enough oxygen pa rin siyang natatanggap. So kailangan mag-infuse ng O2 or ng oxygen. Also stop oxytocin infusion if you're infusing. And lastly, contact the doctor. Important to learn about the periodic fetal heart rate changes to be able to determine the risk factors if these periodic fetal heart rate changes occur to the mother and especially to the fetus. It is also important to us nurses to know the proper measures or the preventive measures that we should do in order to reduce the maternal and fetal morbidity and mortality. And that concludes our topic.
Uterine contraction. Uterine contraction reduces uteroplacental blood flow measurement of intrauterine pressure. So, in labor demonstrates that uterine artery blood flow during diastole decreases during contractions as pressure rises and falls to 0. So, when IUP reduces 35 to 60 mmHg.6, so fetal umbilical blood flow is much less affected. However, the fetus can generally compensate for the short-lived interruption of circulation. So, however, if fetal pressure is already compromised, of it there is a tectonic contraction. Fetal asphyxia can occur. Pain and stress of labor pain causes significant. So, increases in sympathetic nervous system. So, activity and circulating maternal catechomesis. In the absence of hypertension, generally studies in both gravid. So, sheep models as well as humans show no change in uterine blood flow. So, conversely, relief of pain may decrease sympathetic activity and hyperventilation, increasing uterine blood flow. So, particularly in preeclampsia. So, uterine tachystool. Uterine tachystool is a condition of excessively frequent uterine contractions during pregnancy. So, less than 5 contractions in 10 minutes. A range over 30 minutes. If sustained, could lead to fetal distress.
Contraction intensity. What causes contraction? Contraction starts when the pituitary gland releases the hormone oxytocin. This stimulates the muscles in the uterus to start tightening and relaxing. The contractions make the top of the uterus tighten to push the baby down. The intensity of the contractions can be estimated by touching the uterus. The relaxed or mildly contracted uterus usually feels about as firm as a chick. A moderately contracted uterus feels as firm as the end of the nose, and a strongly contracted uterus is as firm as the forehead. Uterine contractions can compress the blood vessels in the uterus, potentially interfering in the transfer of oxygen to the placenta and the baby. In a normal labor, one contraction every 2 to 3 minutes or less than 5 contractions in a 10 period is ideal. A uterus must rest between contractions, having sufficient uterine resting tone, the softer touch, and uterine resting time about 1 minute. Contraction intensity can only be assessed with IUPC. It is a device placed inside a pregnant woman's uterus to monitor uterine contractions during labor. We will look at 10-minute window of contractions. For each contraction, subtract nadir, which is the lowest concentration of a drug in the body, from peak of contraction. Add up these values, which represent contraction strength, measured in MVUS or the Montevideo units. 200 Montevideo units or greater is considered an adequate contraction pattern that should, in theory, be enough to promote cervical change. Intrauterine resuscitation. Intrauterine resuscitation is easy to perform and can result in a significant improvement in the in utero fetal condition. Intrauterine resuscitative measures are commonly initiated during labor with the fetal heart rate. Pattern is indeterminate or abnormal. The most effective use of these measures is directed at the presumed underlying cause. However, some fetal heart rate patterns are non-specific, while others are such that intrauterine resuscitation will not remedy the situation. The goal of intrauterine resuscitation during labor are, at its best, to reverse any hypoxia that might lead to further deterioration, and at the very least, to avoid prolonged periods of indeterminate or abnormal fetal heart rate patterns, which may cause unnecessary concern for caregivers and patients and unnecessary operative intervention. Intrauterine resuscitation consists of applying specific measures with the aim of increasing oxygen to deliver to the placenta and umbilical blood flow in order to reverse hypoxia and acidosis. Intrauterine resuscitation encompasses material repositioning, reducing uterine activity, oxygen administration, amnio infusion, optimizing maternal fluid status, and correction of hypotension, and modifying maternal expulsive efforts. The intrauterine resuscitation or intervention, the oxygen, IV fluids, reposition of mother to the left side lying position, assess maternal blood pressure, especially if shortly after epidural placement. Check the cervix, which delivery imminent or called cord prolapse. Stop the oxytocin if this agent is being used, and lastly, terbutaline can be given to space out contractions, especially if tachycystole is a concern.
Good day everyone, I'm Marie Casteta Corameng, and today I will be discussing about the guidelines in reviewing for fetal heart rate monitoring. So based on our module, for the normal patient should be reviewed every 30 minutes in the first stage of labor and every 15 minutes in the second stage of labor. So labor has 3 stages. In the first stage of labor, the body prepared to give birth. There are 2 phases, early and active. Early labor can last from hours to days. First-time moms may spend more time in this phase. The cervix or the opening to the uterus begins to soften, efface or thin out, and dilate or open. The cervical changes are necessary so the baby can pass through. Usually, a woman's water breaks during the first stage of labor. Contractions or tightening of the uterus became stronger and regular. Typically, the woman will have a 30 to 70 seconds long contraction every 5 to 20 minutes. There may also be stringly bloody discharge from the vagina called bloody show. This is considered normal. Active labor occurs when the cervix starts to dilate more quickly. Contractions get stronger, last longer, and occur more often. The cervix continues to open wider to about 10 cm, then pushing can start. In the second stage of labor, the child is born. A healthcare provider usually encourages the woman to push to help the baby move down the vagina. She might push for minutes or hours. Once the baby's head starts to come out, called crowning, a provider guides the rest of the baby out. Childbirth is finished when the baby is completely out of the vagina. The provider then cuts and clamps the umbilical cord, which connected mom and baby during pregnancy. And the last stage of labor involves delivery of the placenta or afterbirth. During pregnancy, the placenta supplies food and oxygen to the fetus. Once the umbilical cord is cut, the placenta has to come out. Contraction typically begins 5 to 10 minutes after the baby's birth. During this time, the placenta detached from the uterus. A provider may encourage the woman to push just as she did to deliver the baby. After 5 to 30 minutes, the placenta comes completely out of the vagina. Then the process is complete. So, it is important to our part that we should be aware and have enough knowledge on taking care of our patients. So here are the guidelines before the procedure for external fetal heart rate monitoring. So first, your physician will explain the procedure to you and offer you the opportunity to ask any questions that you might have about the procedure. And of course, it is important for you may be asked to sign a consent form that gives your permission to do the procedure, and you should read the form carefully and ask questions if something is not clear. The consent form for fetal heart rate monitoring may be included as part of the general consent for your labor and birth. The fetal heart rate monitoring is performed in conjunction with another monitoring procedure such as a non-stress test or biophysical profile. You may be asked to eat a meal before the procedure because this can help increase fetal activity. You may or may not be able to eat or drink with fetal heart rate monitoring during labor. Although the gel applied to the skin during the procedure does not stain clothing, you may wish to wear older clothing or a hospital gown, as the gel may not be completely removed from your skin afterwards. And last, based on your medical condition, your physician may request other specific preparations.
Guidelines in reviewing fetal heart rate monitoring. For the complicated patient, we have the stage wherein patient should be reviewed every 15 minutes, and for the second stage, patient should be reviewed every 5 minutes. Guidelines. During the procedure for external fetal heart rate monitoring. First, depending on the type of procedure, you may be asked to expose your abdomen, undress from the waist down, or undress completely and put on a hospital gown. Second, you will lie on your back on an examination table. Third, a clear gel will be applied to your abdomen. The gel acts as a conductor. Fourth, the transducer will be pressed against the skin and move around until the fetal heartbeat is located. You will be able to hear the sound of the fetal heart rate with Doppler or an electronic monitor. Fifth, during labor, the fetal heart rate may be monitored intermittently or continuously depending on your condition and the condition of your fetus. Sixth, our continuous electronic monitoring. The transducer will be connected to the monitor with a cable. A wide elastic belt will be placed around your back to secure the transducer in place. 7. The fetal heart rate will be recorded in the medical record. With the continuous electronic monitoring, the fetal heart pattern will be displayed on a computer screen and printed on the graph paper. 8. You may or may not be allowed to get out of bed with continuous external fetal heart rate monitoring. 9. Once the procedure has been completed, the transducer will be removed and the gel will be wiped off.